Well, thank you, Byron, for having me on and putting together this conference here. It's a privilege to talk to everyone today. And so I was sort of tasked with the Herculean task of updating some advances in knee surgery and quickly realized that that's quite a broad topic. So I sort of pared this down to talk about specifically ACL surgery. And we'll take a look at what we're doing currently and the advances we made. But I think to do that, we kind of have to look backwards and see what we've done in the past. So I had no conflicts. Sorry, I did not put that slide in, but no conflicts relative to this talk. And so here's the general outline of what we'll talk about here today. So specifically about ACL surgery, looking at a historical perspective and where we got to where we are today with regards to our current surgical technique, where we sort of have now maintained our status quo on contemporary techniques to reconstruct ACLs, advances that we've made, some advances in pain management, and then a little bit on rehabilitation. Won't touch too much on that. I know that Ben Glecht is going to do a great talk this later on after the break. So what is the problem? ACL injuries are common. About half the knee injuries on an annual basis, and we do about 200,000 ACL reconstructions each year in this country. And that number is probably higher. This is a little bit of earlier data. The demographics are certainly skewed towards female athletes with a 4 or even 5-to-1 ratio. Females tend to sustain them at a younger age. And, even with males, this problem in the young athlete is becoming increasing as we're getting to earlier specialization in sport. And so our ability then to, one, recognize these injuries and then appropriately restore stability into the knee is paramount to try to prevent future degeneration or improve function in our patients. So we can't exactly know where we are today or how we got there without looking behind. And so we'll kind of go through a short little historical tour of ACL surgery to where we got to today and some of the things that we're doing in the future, or currently rather. So the history of ACL dates back to earliest reports in the 1900, when Battle, the first written report was of open repair of an ACL. And early on, the attempts at restoring stability of the knee was really focused on repairing the native ACL. The earliest reports were then sort of reported in the early 70s by Fegan on all of his West Point data, and the results were pretty much dismal. So that sort of focused then more on extra articular procedures to try to restore stability of the knee. But remember, at the time, it really wasn't so much of a debate early on how we should treat these. It was really, should it be treated at all? So this was back in the infancy where we were really trying to figure out what the ACL was and what it was doing. Houston, one of the forefathers, Dr. Houston, one of the forefathers of sports medicine, argued initially that the ACL could be totally left alone as long as you manage the meniscus and the capsule injuries around the knee. So clearly we hadn't really gotten the concept of the ACL yet. But then in Galway then published that pivot shift phenomenon. Houston really latched onto this in the 70s and started to popularize the concept of the anterior lateral rotary instability of the knee with regards to ACL injury. And these are really where the procedure started to develop. And again, early on, after the abandonment of primary ACL repair, was focused on extra articular procedures to restore stability. And so one of the more well-known was the Macintosh 1 in figure 4B here, which basically was harvesting a strip of the IT band left attached at its distal attachment and then looping it underneath the LCL and the gastroc and then back down to itself. There are many, many variations of this. Andrews in the bottom right was sort of a concept thinker when he was really developing and recognizing that there needed to be some differential tension depending on the knee inflection or extension. And so sort of tension them differently, two different strips of the IT band. But again, all of this was focused on extra articular procedures. Well, look, you'll see as we go back into the advances, we'll have to go back to look at that to see what we're doing now currently. But then the 80s came along, the Lockman test was described, Frank Noyes was doing his research then on the ACL and really kind of then was discovering that the ACL was really the primary restraint to anterior translation of the tibia as well as the rotatory instability. And then the focus shift towards the intra-articular procedures. Again, a myriad of techniques. Probably the one that sort of led to where we are today was first the Campbell procedure, which was the first to use the bone patellar bone graft, which was actually left attached at its distal attachments, routed through a tunnel in the tibia and then intra-articularly. Then the Macintosh came along as a variation of its original extra-articular procedure, with then looping the IT band through an overtop position and then into the knee joint. But really it was Clancy that sort of developed this free tendon, free tissue bone patellar bone graft, which was an intra-articular graft. Remember, at that time, though, it was an open procedure, so big, open, almost total knee approach to the knee. And at that time, they used the medial third of the patellar tendon. As the 80s developed, so did our arthroscopic capabilities. They experimented a little bit with synthetic Gore-Tex graft, which turned out to be a disaster as those things blew up in the knee and caused a lot of reaction. Then we came to our outside-in 2 incision technique using a free bone patellar bone graft, and then finally got to our single incision, more modern arthroscopic technique, which sort of has remained that gold standard that we use today. So we could talk for days about how we got to where we are today and all the different techniques and intricacies of ACL reconstruction. But the bottom line is, I think the most current and recent techniques sort of go on the concept of an anatomic placement of our graft, both on the femur and on the tibia. And to do that, most people nowadays are using what we call independent drilling of both tunnels. And so instead of doing a transtibial technique where you're going through the tibia into the femur all in one, we realized that really if you want to get the graft where it should be as an anatomic position on the lateral femoral wall, we really need to get there separately. And so there's techniques where we use a retro cutter drilling from outside in, or we do a far anterior medial portal and really hyperflex the knee, or now probably more commonly we're using these flexible reamers where we don't have to do any fancy manipulation of the knee. They can go around the condyle and get it to where we want. So that's sort of where we are today. Now, one of the biggest surges in research has been graft choices. What's the right graft? And traditionally we have, our 2 main options of allograft versus autograft, all with different configuration, from all soft tissue to bone, patellar bone in the allograft group. Our autograft really has remained as 3 main sources: our hamstring as the most utilized probably in the world, our quadriceps tendon, and then our bone patellar bone. We'll talk a little bit more about quad moving forward. So advantages and disadvantages of allografts: 1, there's no harvest time. There's no morbidity to the donor from taking a cadaveric tissue. You get a predictable size. You can order any size graft you want. Theoretically, some less pain in early initial recovery. However, there's a cost to it. And so there's, $1,000 or more per graft. We'll look particularly in the higher failure rates among the youth athletes with using allograft tissue, the potential for disease transmission or failure and incorporation of the graft. And so if you look at it, and there's been many studies that sort of proven this, that in the younger population, particularly in 18 and below, the re-rupture rates are much higher using allograft tissue. Now, this was back looking mostly at irradiated grafts, which we know significantly decrease the strength of the graft. Some of the other studies that have been coming out more recent with non-irradiated grafts has shown maybe a little bit more of a favorable result, but still in that younger age population run the risk of increase of rupture. So really, in anyone under age 18, I personally will not use allograft unless there's a reason I have to. Looking specifically at our different grafts here, so patellar tendon, as we looked at one of the original grafts to be developed when we went to free tissue grafts, so it has a very long track record with very good results. You get predictable size, and the advantage, I think, is getting bone-to-bone healing. So the 2 plugs of bone that you take heal directly into your tunnel and maybe have earlier incorporation. Some of the downsides that are out there is, 1, the pain from the harvest itself, and then this concept of anterior knee pain moving forward after recovery in patients just having front of the knee pain or inability or desire to not kneel on the knee. There is a little bit of numbness from the harvest site itself, and it does take a little time to harvest. So the hamstring tendon worldwide is the most used graft. Biomechanically, a 4-string hamstring tendon graft is the strongest. Theoretically, there's a potential for less front of the knee pain. Now the downsides are it's variable depending on your patient size and age and the volume of graft that you can get. So you can't quite predict preoperatively what you're going to end up with. There's a potential to harvest earlier. There is the phenomenon of hamstring weakness, and some athletes may not tolerate it as well, particularly soccer players. And so we looked at this. This has been well documented as well in coming out of the Moon data. At the size of a hamstring autograft correlates to failure rate, and what they found was 8 millimeters was really the magic number, and anything less than 8 had about an 18% failure rate. And this has been repeated more and more. And so we thought then at the time we were smart. So if we get a small graft under 8, let's add some cadaveric tissue to beef up our graft and make it over 8 millimeters. There's a few studies that said that maybe the failure rates were lessened because of that, but then there's been multiple studies now that show if you add cadaver tissue to a small hamstring graft, the re-rupture rate is actually higher than if you had a small graft. And so that's sort of been abandoned. And so, okay, now what's the advances in our autograft potentials? Let's look at something new here. So one of the things that's been recently popularized, particularly in the last 10 years, is this quadriceps tendon graft. And if you look at the number of publications in the last 5-10 years, it's grown exponentially. Not surprisingly, though, this is not a new concept at all. Marshall actually described this graft back in 1979. It just never really gained traction as the bone patellar bone took off. So for me, this has really been, I won't say a game changer, but it's really been a great quiver in my armamentarium in tackling ACL injuries and my ability to use different grafts for different situations. So if you look at the gross picture of the quadriceps tendon, it's a very broad tendon, 5 centimeters or more medial lateral, and then predictably you can get greater than 7 millimeters of graft length after harvest about 90% of the time. The way that we harvest has really developed. We can now get it through a tiny 2-centimeter incision horizontally just at the superior pole of patella and harvest it using this proprietary but actually very good harvesting technique to get your graft. So some of the advantages, maybe one, it's a strong graft. It's been shown biomechanically to be stronger than the BTB. It's way stronger than your native ATL. It's probably still a little bit not quite as strong as the quadrupled hamstring, but certainly gives you the strength that you need to support what a native ACL would. And if you look at the concept of what does harvesting patellar tendon or quad tendon do to the overall extensor mechanism post-surgically, if you look at the post-harvest strength of a quad tendon, you're still at 2,400 newtons, and then the intact patellar tendon is 1,900. So it may leave a stronger extensor mechanism behind after you're compared to harvesting a bone patellar bone. If you look at the graft, this is on the left, your patellar tendon, and then this is your quadriceps tendon. I call it sort of the patellar tendon cubed because it's the same width and length, but it's 3-dimensional. And so you can get basically a 9 by 9 by 9 cubed graft and have, up to 88% more volume of graft in the joint. And to date, all the outcomes have really shown it is as good as the other grafts. There's been a lot of research on this, and as I mentioned, there's much, much more upcoming. And so for me, this has been something that I've been using now for when traditionally maybe I would require a hamstring graft. So someone who is skeletally immature and you can't put the bone plugs across the growth plate, but you don't want to deal with the potential for having a small graft. The quad has come in very nicely because even in the younger, smaller kids, it seems to be predictably big. And then for people who then are over the age of 35 or 40, which traditionally maybe we would talk about allograft a little bit more aggressively, the quad has been very nice because of the low morbidity we've seen with the graft harvest site. So it's something that really I think is going to find its role as we continue to research this. All right, so go to the future. We have to go back to the past here. There's been a resurgence of looking at the lateral side of the knee as we're trying to optimize our outcomes from ACL surgery. The failure rates after ACL can be exceedingly high, especially in those younger populations, especially female soccer players, as high as 40% of tearing the same ACL or the other ACL. And so trying to figure out how we can get better stability of the knee is something that we're really looking at. And so the Sagan fracture has sort of been associated with ACL tears, which is this small little avulsion fracture off the anterior lateral tibia, and it's been pathognomonic for an ACL tear. But what we have found is that that's actually an avulsion fracture of a now described structure called the anterior lateral ligament of the knee, basically capsule thickening, but a discrete ligament that then runs from the lateral epicondyle to the ALL. So there's been an extreme interest in this and whether or not this is something that needs to be addressed as well. And so going back to the beginning, right, we're now going back to the lateral side of the knee. And this is a study that's looked at an actual anatomic reconstruction using allograft tissue of that ALL and was finding that the re-rupture rates have been lower in the groups that have been ACL and an ALL. Certainly the research on this is ongoing. It's a hot topic right now, trying to figure out who, if anyone, needs this or would benefit from this. The other concept is the lateral extra-articular tenodesis. And so that same issue of trying to get some rotatory instability in the lateral aspect of this knee. This was actually a randomized trial looking at hamstring graft alone versus hamstring graft plus LET, which basically is taking a loop of that IT band, going behind the LCL, tacking it to the femur and back to itself. And they found a decreased re-rupture rate in that group compared to the ACL alone. And if you look at that, this looks oddly familiar as to what we talked about with the Macintosh. And so this is basically a Macintosh 1 procedure. But it is garnering a lot of attention. And for me, has been very interesting, and especially in cases with a revision with a high-grade pivot shift as something that we will utilize to help decrease that rotatory instability, or even in kids with real high risk factors for failure, hyperligament laxity, contact sports or cutting, twisting, pivoting sports at a high level, and then a very high grade pivot shift examination or anesthesia. So certainly something that we're looking at and that we're going to be writing about in the future, trying to optimize our outcomes. Additionally, another surge in interest has been the concept of primary repair of ACL tears. And so in the rare circumstance, I guess, when you look at the overall morphology of ACL tears, sometimes the ACL tears actually do avulse off the femur, and there's a potential to repair them. There's been a resurgence in looking at this and our ability to then just repair our native ACL back to its footprint using just primary repair or suture augmentation to sort of repair and then offload our repair. And then again, this looks oddly familiar to the initial descriptions on the ACL tear in the early 1900s. And so if you look at this, this was a randomized trial that looked at this with only 2-year outcome data, so we're not looking very far into this, but showed that there was no real difference and they weren't inferior to an ACL reconstruction. There's been a lot of literature recently coming out of this and a lot of popularity in the concept of repairing ACLs. But if you look at this high risk group, so people under the 18, the risk of failure was almost 50% at 3 years after surgery. And so I know we're going back in history here, but it looks like at least some of this stuff may be repeating itself. And so maybe ACL repair is not something that is going to gain any traction moving forward, but it's certainly gaining a lot of attention in the research. So moving and switching gears a little bit, our ability to transition from what used to be an inpatient open procedure required of, days in the hospital, casting, and delayed physical therapy has then now exclusively been transitioned to an outpatient surgery with immediate ambulatory physical therapy beginning within days of surgery. And our ability to do that has hinged on our ability to use regional anesthesia, which we'll talk about a little bit later, and then pain management going home. And so obviously the opioid pandemic here has really garnered a lot of attention on how we can better control pain without using opioids. And a lot of the procedures we're doing in sports have sort of gone to this, not even sports, joint replacement as well, and all other aspects on multimodal pain control regimens. And so one of our answers for this is a paper that we just published in JAOS looking at adding oral ketorolac for a limited time after rotator cuff surgery. And so basically we randomized people to either receive the standard nerve block in pain medicine or the standard nerve block pain medicine in addition to 3 days of scheduled oral Toradol. And we found in this study that was recently published a decrease of about 50% over 50% actually in the narcotic use in the first week. So we sort of transitioned this and translated this to the ACL world. This is a study that we actually, a randomized control we just completed. It's off in the publication, submitted for publication phase right now, but found almost the essential, the exact same results. We used the same concept, standard regional nerve block plus traditional pain medication versus regional nerve block plus ketorolac and pain medication, and found 45% reduction in narcotic pills, a significant decrease in pain scores, and no difference in outcomes or side effects, which was something certainly we were happy to see. And if you imagine that a lot of these patients are the younger population, any decrease in opioid exposure, I think, is key. Addition to that, we're looking at how we can better optimize regional nerve control, pain, anesthesia after surgery. And so we've been using in our surgery center something that has come out of basically the total knee literature, looking at regional nerve blocks called the IPAC. And so it's the IPAC stands for the interspace between the popliteal artery and the capsule of the knee. Basically, it's an infiltration just ventral to the neurovascular bundle, while adding also a femoral nerve block to help decrease postoperative or posterior pain. And it's been shown to decrease opioid consumption and improve pain scores. This is sort of what they're doing, local infiltration under ultrasound in that space just behind the femur and ventral to the neurovascular bundle. The advantage is that you don't get any motor loss from this. And there's been some early research looking at this with ACL, so combining a femoral nerve block with the IPAC, showing decreased opioid consumption. We've been using this at our surgery center and have had very good pain control, and really are having kids now come in with their first post-op appointment saying they took 1 or 2 pain pills and that was it, which is great. That's what we want to see. So then lastly, just touching a little bit on rehab, gone are the days of casting and delayed rehab with ACL surgery. We're recognizing that early aggressive therapy is key to recovery. We really have been pushing cryotherapy to decrease the effusion and inhibit quad inhibition and get our quad firing early. Early weight bearing has led to decrease of patellofemoral pain, really emphasizing early passive extension in those first couple of weeks so that we're not chasing our tails in the months afterwards. And there really has been no difference in outcomes between early accelerated rehab and non-accelerated. In the early phase, we focus on exercises that don't place stress on the graft. So isometric hamstrings, isometric quads, or simultaneous quads and hamstring contraction. Active knee motion between 30 and 90 are safe and easy on the graft, and then focusing on core and glute strength as well. And things we really want to avoid is anything that's going to stress the graft, so isokinetic quads and particularly open chain quad strengthening. I'm not going to talk about this a lot because I know Ben Galecta will, but this is something that we're excited about in the rehab of ACL surgery, but also all knee injuries in general. We're using it with the monsters. I'm using this concept of blood flow restriction therapy early on in my ACL reconstructions. And the idea is, without too much detail, is putting a non-occlusive pneumatic cuff on the thigh. And what that basically does is allows you to exercise then the muscles of the lower extremity with minimal load, so a few pounds, and getting the benefit of a full weight workout. And so there's been a lot of literature on this. A lot of it's coming out. It hasn't totally been hashed out, but there's been some evidence that it leads to early hypertrophic benefits of quad bulk. And so it's something that we're really utilizing. I think have been great for our patients, and it also gets them in the game earlier, so that's something else that they can do in those first couple of weeks than just quad sets and heel slides. So that's something that's on the horizon. That's all I have. I know I was the last thing that was between lunch, so I appreciate the opportunity to talk. We could talk about ACL surgeries for the next 2 days if we wanted to, but those are some of the highlights of the things we're doing now, and happy to entertain any questions if anybody has any.